So I get to be the light entertainment and play the role of the crazy allergist who thinks it's all about her allergies. So I'm going to talk about whether or not it would make any sense to add omalizumab to this patient's care. I will skip over some of this. Actually, I have a little bit of time. I won't. So omalizumab is a monoclonal antibody. Where's the pointer? So it's almost entirely human IgG, except for these little bits at the end, which are still mouse. And it binds to the third constant region of the IgE molecule. So for the fellows, an IgE molecule can bind to omalizumab or it can bind to one of its IgE receptors, but it can't do both. And I just had to show this figure because it's a nice demonstration of the different places that omalizumab works in the generation of IgE-mediated inflammation. So the top panel is a regular state in an atopic person. Bottom panel is in the presence of omalizumab. And we usually focus on what happens to the end effector cell, the mast cell, as well as the basophils. When you give someone omalizumab, it reduces their free IgE by approximately 96% pretty quickly. But then over the next few weeks, you get a downregulation of Fc epsilon R1 receptors, rendering the cell less able to react to allergen. But just to remind everyone that it also acts at the dendritic cell, where allergen is being taken up and presented to T cells, which then interact with B cells, which also use IgE. The B cells turn into plasma cells and make IgE. So it's actually acting at the end effector cells, the B cells, the dendritic cells. And patient selection, I think we can skip over for this audience. So in trying to decide if this would make any sense in this particular patient, whom we don't know her atopic state, it's useful just to ask the question, how common is allergic asthma? And the answers to this are really all over the map. But the question that's usually posed is, what percentage of patients with asthma have evidence of atopy as judged by positive skin tests? Of course, you can have a positive skin test or a positive serum immunoassay and not be clinically reactive to that allergen, so it's an indirect answer. But the information we have, there's a recent study in 2007, which was a nationwide survey done in the US, identifying patients with asthma and then finding out how many of them tested positive to various allergens. And 78% of them did. They then did a calculation to figure out what percentage of asthma was attributable to allergy, and they calculated 60%. But I think for our discussion today, really it's what's the likelihood that this patient is eligible for omalizumab. Then if you look at certain subgroups, you find even higher rates. So among children who are admitted to the hospital for wheezing, positive skin tests were found in 83% versus 33% of children who were admitted for other reasons. And I don't think, unless I could be wrong, but I couldn't find any studies where they'd actually challenged large numbers of patients to determine what the rate of clinically applicable atopy was. So the next question is, how well does this therapy work? We don't have studies that compare omalizumab to inhaled corticosteroids or inhaled corticosteroids and LABA, but we have studies that tell us roughly how well it works. And I was going to focus on a systematic review that was published this year by Rodrigo et al., partly because every single study that's been published with omalizumab has been funded by pharma. So I think that our systematic reviews are our one independent source of information. So this study looked at 8 randomized trials, including 2 pediatric trials. Over 3,000 patients, including children as young as 6. 6 is the age beyond which it's used in Europe. And all patients had moderate to severe asthma. Serum IgE levels were slightly different. We used 30 to 700. They used 30 to 1,300. And 5 of the trials were structured the same way, which is a steroid stable phase in which omalizumab was added to current therapy. Current therapy was always moderate to high dose of inhaled corticosteroids. People could be on other therapies, but it had to be similar in the placebo and omalizumab group. And then a second phase in which steroids were gradually reduced and patients were monitored. And the primary outcomes used in every single one of the modern studies are reduction of exacerbation rate and reduction in steroid use. So just looking at each of those outcomes independently. So reduction of steroid use. Subjects were able to withdraw from steroid therapy entirely in 42% of the omalizumab groups and 21% of the placebo-treated patients. And the number needed to benefit was 5. Patients were able to reduce steroids by greater than 50% in 76 versus 56. At the end of the studies, the mean difference in steroid dose between omalizumab and placebo-treated patients was relatively, there was a relatively modest decrease in steroid use in the omalizumab group. And then looking at exacerbations, this forest plot I think is the easiest way to look at it. So the studies are really quite consistent, showing that the relative risk for at least one asthma exacerbation during the steroid stable phase is half. And expressed in different ways, exacerbations per person were 38 versus 70 per 100 patient years in the omalizumab versus placebo. The number needed to benefit was 10. And this is a point that's often discussed. The exacerbations requiring hospitalization, so the relatively more severe ones, are reduced a little bit more. However, when they looked at pulmonary function and quality of life measures, which are improved in some studies, but in the systematic review, that didn't really pan out. The next thing that was addressed in this review was safety. So less than 2% of patients withdrew from the omalizumab and placebo groups due to treatment-related adverse effects. So it's a well-tolerated treatment. Injection site reactions definitely happen. Anaphylaxis happens, although it's as low with omalizumab as any biologic. It's just gotten a lot of press because I'm not quite sure how it happens. And then the other two issues are malignancies and cardiovascular adverse events. Malignancies, in this set of studies, these recent studies, there was one in each group. In cardiovascular events were all in the placebo group in this particular review. But these two things probably would not show up in a group of studies that were all performed within a year's time. So we need longer exposure to really know more about these. And there's a study underway, epidemiologic study of Xolair, evaluating clinical effectiveness and long-term safety in patients with moderate to severe asthma, the EXCELS trial, that will hopefully tell us some of that information. There's some important things we don't know about omalizumab. One of them is what percentage of patients respond. And you really can't tell from the published trials. This information is not available as far as I can tell. And I came to that conclusion sort of preparing for this, and then I emailed Peter Barnes, who works with me at UpToDate on the omalizumab card topic. And he said, without my prompting, you can't tell that. It's kept very close by the industry. And so I think, this is very telling in itself. It's probably lower than we wish it were. I went back to the very earliest studies thinking maybe they would be a little less polished. And I looked in a study published in 1999 that found that at 12 weeks, about 1/2 of omalizumab-treated patients reported a 50% improvement in asthma score, compared to 25% in the placebo group. So maybe a 25% response. The other thing is, in all of these studies, the placebo groups do very well, and it's probably because they're being monitored so closely and they're perhaps more compliant with their therapy, but placebo responses are high in these studies. The other thing that would be really nice to know about omalizumab is what factors predict a strong response. IgE levels within the range of people that we're treating now don't seem to really predict who's going to respond strongly versus who's going to get a little bit better. An early study of moderate to severe asthmatics found that patients were more likely to respond if they had low FEV1, high inhaled steroid needs, and frequent ER visits. So the more severe patients seem more likely to respond. And that was done by this same group, Bousquet, and they did a subsequent analysis a few years later where they focused just on those most severe patients. And they looked at over 50 baseline characteristics to see if they could pick out any that would distinguish responders from non-responders. And they concluded that there was no easy way to do this. And what they ended up recommending was simply that the physician's impression of how the patient was doing, and after 4 months of therapy, identified most of the people who ultimately responded well. And I thought it was interesting that in this study where they clearly had to count responders and non-responders, they didn't say who they were or what percentage they represented. So omalizumab has many strengths as a controller therapy. It's applicable to a large number of asthmatic patients, as we've discussed. The other ways of treating the allergic component of asthma, meaning environmental control measures or immunotherapy, both have their own sets of issues. So environmental control is expensive and difficult for the patient. It doesn't work that well. Immunotherapy works, but it's extremely inconvenient for people. It's time-consuming, and it has risks. Omalizumab treats the allergic rhinitis that contributes to allergic asthma, so it treats the entire airway. It's a monitored therapy, so compliance is known. It has the added benefit of requiring contact with healthcare providers and closer monitoring. The expense may prompt patients to refocus on their asthma as an important issue and may improve their compliance with other therapies. And finally, in a study by Bussey this year on inner-city children with asthma, it was found that omalizumab might help with exacerbations triggered by viral infections. So they monitored the incidence of viral infections in children over the period of the study. It was the same in placebo and omalizumab groups, but the omalizumab group had fewer and less severe exacerbations during those times. Mechanism hasn't been postulated and it needs further study, but however, it's very expensive. And there have been some really nice analyses of the expense done by people here. It's over $700 for the smallest vial now, which is 150 milligrams. And the maximum dose that some patients will need would be 3 vials every 2 weeks. That's worst case scenario, but the bottom line is it's incredibly expensive. So I may have been supposed to argue that we should add omalizumab to this patient, but I honestly can't. But I do think that omalizumab as a therapy is a really nice and useful option that will not go away and will become more useful. And perhaps it won't be in mild to moderate asthma. Perhaps it'll be in other things. The things that would really help and make the therapy more useful, obviously a competing preparation to push costs down. This may be more likely as we find more and more uses for this drug. We're applying it. We have the first randomized controlled trial published this month for urticaria. And we have food allergy, which is an open question. We would also need a better way to determine which patients are most likely to respond, short of a 4-month therapeutic trial. And it would be really nice to have the information about what percentage of patients are strong responders versus people who respond like they would to more corticosteroids. And finally, and this is really important for, I think, this patient's case, we need more time to see if these rare adverse effects are really there. Particularly if we're talking about putting people who are at relatively low risk with their asthma. Our patient had just 1 emergency room visit. If we're talking about putting her on a lifelong therapy that we don't exactly understand the immunologic effects of, I think this last point is very important because there's this issue of malignancy with omalizumab, and we would probably only see that after decades of therapy. It's probable that omalizumab doesn't cause a cancer. The cancers that were seen in the studies were all different types of cancer, but it's very possible that it affects your ability to do effective immune surveillance. That's much more likely, I think. And the fact that the studies were all, or the fact from the early studies that the cancers were all different fits with that. Likewise, in the early studies, there were people who had cancer in remission, and they said, well, they shouldn't have been included in those studies. But actually, maybe those are exactly the kind of people we want to study, because maybe they're people who are keeping their cancers in check, and then you release some brake, and something happens. So I think for our patient, she's much more likely to be at risk for cardiovascular disease or malignancy as she ages than to die of her asthma. So I wouldn't put asthma into this person's therapy. I mean, omalizumab, but I do think it's an excellent option.